Recording in progress.
Ben Gladsam et al. Studied the use of cetuximab with FOLFIRI as first-line treatment for metastatic colorectal cancer. They found, compared to FOLFIRI alone, FOLFIRI plus cetuximab reduced the risk of progression in patients with KRAS wild-type tumors, improved surgical resection rates 7.0% versus 3.7%, and improved R0 resection rates with curative intent 4.8% versus 1.7%, p equals 0.002. Bokemeyer et al. Showed a similar effect with FOLFOX plus cetuximab. In this trial, they showed increased OS and response rate 61% versus 37%, p equals 0.011, and reduced disease progression, HR 0.57, p equals 0.163. In patients with KRAS wild-type tumors receiving FOLFOX plus cetuximab as first-line treatment of metastatic colorectal cancer. The SELEM trial directly compared cetuximab with either FOLFOX or FOLFIRI in patients with unresectable colorectal cancer with metastasis isolated to the liver. Both groups demonstrated high response rates, 68% in the FOLFOX group and 57% in the FOLFIRI group, and increased resectability rates 32% at baseline to 60% after chemotherapy, p less than 0.001. Conversely, the MRG-COIN trial evaluating the addition of cetuximab to an oxaliplatin-based regimen for first-line treatment of advanced colorectal cancer demonstrated increased response rates, but no survival benefit or increase in the number of potentially curative liver resections, even in patients selected by additional mutational analysis. However, given the numerous other trials that have shown a substantial benefit in terms of both response rates and resection, cetuximab has been widely used in first-line therapies in patients known to have wild-type KRAS, NRAS, and BRAF colorectal cancer. Panitumumab has also been studied in combination with common first-line chemotherapy regimens for metastatic colorectal cancer. The PRIME trial by Julian et al. Explored panitumumab plus FOLFOX and reported improved PFS 9.3 to 11.4 months versus 7.5 to 9.5 months, p equals 0.01. Improved OS in patients with KRAS wild-type tumors, and improved response. However, there was no significant difference in resection rates. Peters et al. Studied panitumumab plus FOLFIRI versus FOLFIRI alone as second-line treatment in metastatic colorectal cancer and observed an improvement in PFS 5.9 months versus 3.9 months, p equals 0.04. Most recently, the Wolfi trial studied FOLFIRI with panitumumab versus FOLFIRI alone in colorectal cancer with liver metastasis. The combination of FOLFIRI and panitumumab showed significantly higher response rates in patients without ARS wild-type tumors, 85.7% versus 54.5%, respectively, p equals 0.0013, and high rates of secondary resection, 60% versus 36.4%. Though OS and PFS were similar between the two groups. However, treatment-related toxicity was also significantly increased by the FOLFIRI with panitumumab group, 32.8% versus 12.1% with FOLFIRI alone, p equals 0.0297. Anti-VEGF targeted treatment. Anti-VEGF vascular endothelial growth factor therapy has also demonstrated a role in the conversion chemotherapy setting. Wang et al. Showed that Zelox showed that Zelox capecitabine and oxaliplatin plus bevacizumab resulted in high response rates for colorectal cancer patients with liver metastasis with poor risk features who were initially unresectable. Additionally, 40% of patients became resectable with this combined regimen, regardless of KRAS mutational status. The Olivia trial studied bevacizumab plus FOLFOX or FOLFOXIRI in patients with initially unresectable liver metastasis. This study showed that FOLFOXIRI with bevacizumab was associated with improved PFS, 18.8 months versus 11.5 months, response rates, 81% versus 62%, resection rates, 61% versus 49%, and R0 resection rates, 49% versus 23%. As expected, toxicity was increased in the triplet regimen. The TRIBE study assessed bevacizumab plus FOLFOXIRI or FOLFIRI as first-line treatment of metastatic colorectal cancer. This trial also demonstrated FOLFOXIRI plus bevacizumab improved PFS 12.3 months versus 9.7 months, p equals 0.002. 0.06, as well as OS 29.8 months versus 25.8 months, p equals 0.03. However, in contrast to the Olivia trial for bevacizumab plus FOLFOXIRI or FOLFIRI, there was no significant difference in resection rates. Comparison of targeted therapies. The use of anti-EGFR and anti-VEGF targeted therapies has also been compared in trials. The FIRE-3 trial studied FOLFIRI plus cetuximab versus FOLFIRI plus bevacizumab as first-line treatment for patients with metastatic colorectal cancer. While PFS was similar, OS was significantly longer in the group receiving FOLFIRI plus cetuximab than the control group, 28.7 months versus 25.0 months. P equals 0.017, and this was even more pronounced for patients with RAS wild-type tumors. The percentage of patients who went on to secondary resection was similar between the two groups, 36% for the cetuximab group versus 40% for bevacizumab group. In the PEAK trial, Schwartzberg et al. Compared FOLFOX plus panitumumab versus FOLFOX plus bevacizumab. Similarly to the FIRE-3 trial, PFS was similar between the two groups, but OS was improved in the group receiving anti-EGFR treatment with panitumumab 34.2 months versus 24.3 months. P equals 0.009. Again, patients with RAS wild-type tumors gained the most benefit from anti-EGFR therapy. In contrast, Vinuk et al. Studied cetuximab versus bevacizumab added to either FOLFOX or FOLFIRI in patients with KRAS wild-type advanced or metastatic colorectal cancer. They found no significant difference in OS, 30.0 months in the cetuximab group versus 29.0 months in bevacizumab group. P equals 0.08, or PFS 10.5 months in cetuximab group versus 10.6 months in bevacizumab group. P equals 0.45. Sighsedness of the primary tumor, which will be discussed below, also plays a role in suggesting which patients would most benefit from anti-EGFR versus anti-VEGF therapy. Siceness. Colorectal cancer is increasingly recognized as heterogeneous disease, and the side right versus left, where the primary tumor arises, may have both prognostic and predictive implications in clinical practice. This should be considered when choosing a chemotherapy regimen. Arnold et al. Reviewed 6 randomized trials: Crystal, Fire 3, GALGB 8040, 80405, Prime, Pink, and 200508181 to evaluate the prognostic and predictive value of tumor sidedness in colorectal cancer. They found that RAS wild-type tumors, patients with right-sided tumors had a worse overall prognosis in terms of OS, PFS, and overall response rates. Additionally, they showed the effect of chemotherapy combined with an anti-EGFR agent was greater in patients with left-sided tumors than in those with right-sided tumors. Patients with left-sided primaries who received the chemotherapy and anti-EGFR therapy had improved OS and PFS, HRS 0.75 and 0.78 respectively, and a trend toward a greater response and a trend toward a greater response rate compared with side-sided primaries. There was no survival benefit observed in patients with right-sided primaries who received anti-EGFR therapy. In fact, in the GALGB 80405 by Vinuk et al., there was an observed detrimental effect for patients with right-sided tumors who received cetuximab with both decreased PFS and OS. The benefit of anti-EGFR therapy therefore seems to be primarily in those with left-sided primaries. Patients with right-sided primaries may, on the other hand, benefit more from initial treatment with bevacizumab in combination with chemotherapy, given the more aggressive nature of right-sided primaries. These patients may benefit more from triplet therapy combined with bevacizumab to facilitate optimal downsizing. Conclusions: neoadjuvant therapy should be used with the goal of resection. There is a strong correlation between the neoadjuvant response rate and post-metastasectomy prognosis and outcomes. Therefore, predicted high response rates are desirable to increase the likelihood of surgical resection in patients with upfront unresectable disease. Patients should not be overtreated, as this may result in loss of the resectability window and or therapy limiting toxicity from chemotherapy. When assessing response to chemotherapy, change in tumor size as well as morphologic changes should be considered. For patients with upfront unresectable disease, conversion chemotherapy is often utilized in clinical practice with the goal of increasing rates of resection, which presumably improves survival. While numerous trials have shown improved efficacy with triplet therapy combined with a targeted agent, toxicity should be taken into account when considering these regimens. The benefit of anti-EGFR therapies is most marked in patients with left-sided primaries and RAS wild-type tumors. Patients with right-sided primaries may need a triplet regimen alone or with bevacizumab for optimal downsizing. Irinotecan is associated with steatohepatitis, which increases 90-day mortality, so should be avoided in the neoadjuvant setting except in the context of a triplet regimen. There is an increased perioperative morbidity associated with greater duration of chemotherapy exposure, more than 6 weeks. Adjuvant therapy following metastasectomy. The goal of adjuvant chemotherapy following metastasectomy is to eliminate micrometastasis. Much of the data are extrapolated from stage 3 disease, which supports the use of FOLFOX, but not irinotecan, bevacizumab, or cetuximab in the adjuvant setting. Ito et al. Studied combinations for adjuvant chemotherapy after complete resection of liver metastasis from colorectal cancer. In this study, there was no demonstrated survival benefit seen with the addition of irinotecan. Disease-free survival was 21.6 months for fluorouracil plus folinic acid versus 24.7 months for FOLFIRI, HR0, 89, p equals 0.47. Therefore, FOLFOX alone is recommended for adjuvant treatment following resection of metastatic disease in colorectal cancer. In older patients, more than 70 years, or patients with residual neuropathy, it is also reasonable to consider a gentler regimen like 5-FU capecitabine alone. It is also acceptable to consider those monitoring, given the lack of robust data providing the efficacy of adjuvant therapy in this setting. Similarly to stage 3 disease, there are no data to support the use of targeted therapies following resection. However, if a regimen is effective in the neoadjuvant setting, some clinicians select to use the same regimen post-operatively. Conclusions. FOLFOX alone is recommended as adjuvant therapy. There are limited, no data support the use of irinotecan, bevacizumab, or cetuximab in the adjuvant setting.